Good morning, everyone, and thank you for joining us. And welcome to this New South Wales Health NGO sector update focused on the response to COVID-19. My name's Tim Duck, and I'm representing the Health and Social Policy branch at the New South Wales Ministry of Health, who hold the policy and strategic lead for the NGO sector here in New South Wales. Before we officially commence, could I ask that everyone put, except for our presenters, of course, to put their videos off because we have a large number of people participating today. So you can take your camera off by clicking on the video icon at the bottom of your screen. That would be really appreciated. I'd also like to acknowledge the traditional custodians of the land each of us are meeting on today and pay my respects to elders past and present and any Aboriginal and Torres Strait Islander people who are joining us today. Again, I'd like to thank all of you for joining this, I guess, quite an important webinar. And I'd also like to extend my warm welcome to the two other presenters joining me today. Mr. Larry Pearce. Larry is the clinical lead for the New South Wales Health NGO Communities of Practice and is the Chief Executive of NADA. Welcome, Larry. I'd also like
thank you and welcome everyone.
Thanks, Larry. I'd also like to introduce public health expert, Dr. Jan Fazell. Jan is from the COVID-19 response team here at New South Wales Ministry of Health. And welcome and thank you for joining us, Dr. Fazell.
Good morning, everyone.
So it is indeed a challenging time for all of our health sectors, including NGOs that we fund and work with to deliver important health services in New South Wales. As we always do, we've worked together at this important time to be more agile, innovative and resilient than ever before. The NGO sector provides a really critical and important part of the overall New South Wales health system, and by providing health services in the community setting for generally the most vulnerable populations across New South Wales. We also acknowledge the important role that our New South Wales Health grant managers also play. I believe all our grant managers are linking in today to also hear this information. We really rely on our grant managers to work closely with our NGO sector partners to provide the support, guidance and insurance needed to make sure that we continue to evolve and remain vigilant in this time. During the COVID-19 pandemic, New South Wales Health will continue to work in close collaboration with its NGO sector partners. Today's session will focus on sharing the latest advice to keep you informed on the key issues relating to the impact and the response to COVID-19. In particular, we've tailored today's session to be specifically focused on the NGO sector. We won't be able to take any questions live today, mainly because we have roughly 250 participants joining us today. But please send any questions to the email, the dedicated email mailbox that you'll see on your screen in today's session, and we'll work through those issues as a communities of practice and then follow up with you as needed. Also, just to mention, we're recording today's webinar, so it can be shared via our website for those who can't join us today, and if anyone experiences any technology difficulties during the session. I'll now hand over to Jan, who will provide us with an overview of New South Wales Health's response to COVID-19.
Good morning, everyone, and thanks for this opportunity to provide you with an update. We have some good news and some caution coming forward. Just to give everyone a reminder, what do we know about COVID-19? That our population in New South Wales still generally has not been heavily exposed to COVID-19. So we don't have a lot of immunity in our community to this particular virus. There's no vaccine available at the moment, and we know it's going to be anywhere between 6 to 18 months until a vaccine is likely to be available. We don't have a particular directed treatment for COVID-19. There's no antiviral medication that's been proven to be overwhelmingly successful in this disease. But we do have good supportive care. So that can be involving administration of fluids, administration of oxygen, putting people on ventilators, the machines to help them breathe. So most of these people, though, who have gone into intensive care in New South Wales, pleasingly have survived or are still undergoing care. It can be quite a long admission to the intensive care unit whilst the lungs recover from the damage that they've sustained during because of the illness, not because of the treatment. And we have seen a number of older people particularly succumb to the disease. So what have we learnt since we last talked about COVID-19? We've found a lot more information about cases becoming infective before symptoms appear. And sometimes we're finding that because we've got such extensive testing in Australia, we're starting to get a better picture of exactly how mild this disease can be in so many people. And that can be just a bit of a scratchy throat, that can be a runny nose, it can be a change in taste of smell. We found that fever, whilst said to be present in 88% of cases in China, is not nearly as prevalent with our cases here in Australia that we've been discovering. So it is the great imitator. It imitates just about any other respiratory flu-like illness you could name. And that's why in New South Wales we're saying to people, please come forward and get tested. Even if it's a very mild change in your usual baseline runny nose, we'd like to test you at the moment. Most people in New South Wales have had a mild or moderate disease and can be managed at home with just fluid, Panadol and rest. Some people are developing disease, and we have had those people in intensive care. We have had those deaths, as I mentioned, amongst older people particularly, and those with underlying health conditions. But it's not to say that younger people completely escape. It's just that it's much, much rare to have a young person have a severe illness, and it's quite rare for children to become severely unwell. We've also learnt that children don't spread the disease easily. So this is very different to colds and flu, where children are absolute germ factories. For these particular illnesses, we're not seeing that particular spread amongst children or the spread from children to adults. The household and community gatherings seem to be a place where this disease absolutely loves to be, and some workplaces. We've also seen it at religious services. So anywhere where people spend a lot of time together in close proximity, just being with other people as we normally do. So where are we in New South Wales? We had early and sustained high levels of testing, and we also had a very early start to case finding and contact tracing. And I think that put us to some extent on the front foot of this actually coming under control in New South Wales. We don't just rely on our testing data, we've also had real-time surveillance of ambulance use, emergency department attendances, respiratory admissions, ICUs admissions and deaths across the state in near real time. And that means that we're not just relying on one indicator to tell us that things are getting under control. The high testing numbers help us, but also looking for other indicators, because sometimes the first signal that something's gone wrong was with high intensive care admissions. So we've been in the great privilege of not having that signal. Instead, we've often known somebody who was unwell before they've needed to go into intensive care. So our blanket testing has been helpful. We've had the Public Health Emergency Operations Centre stood up since January 2020. We've brought on, an army of contact tracing people who've been trained and able to talk to the people who've been in contact with cases of COVID-19 so that we can counsel them about self-isolation and monitoring themselves for symptoms and getting tested. Since early February, we've been planning for a surge in ICU demand and a surge in hospital demand. And we've had a State Health Emergency Operations Centre, Homebush, stood up looking at whole of system planning. How do we get enough PPE? How do we get people seen in an appropriate and safe way? How do we protect the staff in not just our sector, but across multiple sectors who provide care for vulnerable people? We've been working hand in glove with Department of Community and Justice to make sure that we support our vulnerable communities as best we can. And whilst there are severe impacts in many countries, at the moment we have escaped that in Australia. We know that the difference between us and other countries has been that we've had a strong border control and flexible testing early, and that often things that have happened overseas have been because they've either had low community testing. So that's something that happened in the United States, for example. At the beginning of March, New South Wales had tested more people for COVID than the whole of the United States. So they've had a difficult time in America because they haven't had good testing initially, and then the support for communities to not have that drive to leave home and go to work has not been as strong in some countries. So they've had a very difficult and different time to us. We also know that in some countries, if you don't test, you can't find cases, and that has been one way that they have kept numbers low. So it's a different situation overseas. And we still have the need to do those sustained border messages because we are still seeing people come from overseas for all sorts of different reasons now. But a number of those each day do actually come home to Australia and they do have COVID. So we've escaped the worst, but we still have to be vigilant. We still need to think about our physical distancing. We still need to pay particular attention to how we're behaving with our coughs and sneezes, and we still need to keep our hand hygiene going. So it's no easy way out at the moment because, you know, the pandemic started with perhaps 3 or 4 cases somewhere, so we need to stay vigilant until we've found all those needles in the haystack if we can. So as you can see, we had a significant peak in early March, where this was where we had overseas arrivals from countries that hadn't necessarily identified that they had an outbreak. We saw some early indications, for example, that the UK and the US had a problem before perhaps the UK and the US did, because we were seeing a number of cases in return travellers, not from what we thought were the high-risk countries, which were then around Italy, Japan, South Korea, Iran, and China. We actually saw a number of cases coming through from Europe and the US, for example. We've now got to the point where our curve is pleasingly very flat indeed. However, we still are occasionally finding a case of community transmission, and we do not know where that person has picked it up from. And so whilst ever that's going on, we remain concerned and we need to keep high rates of testing. As of the 6th of May, I haven't, been able to update this slide for today's number, just over 3,000 cases. We've lost 46 people to the disease. As you can see, the vast majority of cases came from overseas. And then what we had some secondary transmission, particularly in family and households. We have had, as I say, those numbers of cases where we haven't been able to find out where it is. We're using a technique called whole genome sequencing, which is where we look at the entire genetic code of the virus in somebody, and then we look for tiny changes, which could be as small as 1 amino acid, to try and help us understand where this or who else might have a virus that looks like this. Because just like making a photocopy, as we make many, many copies of the virus when it infects us, sometimes small changes creep in and that becomes the dominant strain for that particular person. I just wanted to talk a little bit about hotspots, because I know that this has caused quite a bit of confusion in the community. So as you can see here, I've got a week's worth of data for some of our hotspots of interest at the moment. And as you can see, there's not necessarily a large number of cases occurring in those hotspots, but what we are concerned about is when we get history from people. These are the people who we haven't known where they got the disease from, or these are community areas. Because we count our cases by postcode of residence, sometimes the person's been active in a particular community. Either they work there, or they care for somebody there, or they have transacted their necessary business there. And so that's where we test in that particular location where the person has been, as well as where they live. And so this is where you're seeing our areas of increased transmission. So as you can see, it's not that we have thousands of cases, hundreds of cases, or even tens of cases in these hotspots. it's looking for this needle in the haystack and trying to make sure that we don't have anything more going on. And it's only by doing that sort of extensive testing where we're testing, as you can see, 2,000 residents almost in one local government area to try and make sure that we've got a good handle on what's going on there. And we can either relax or maintain that vigilance depending on what we find. So what do we need to keep doing as we're coming through this pandemic? We need to support our communities because we know that there are different groups who have been vastly disproportionately affected by the restrictions that have been put in place for COVID-19. There's huge amounts of community distress, there's financial distress, and we also know that some people haven't been seeking the care they should because of fears that they'll get COVID-19 in healthcare facilities. We also know that it's been a very scary time for a lot of our staff who have been working with communities, and they've been concerned for their own safety and the safety of their families. So trying to help staff regain the confidence that, yes, this is under control. We need to be cautious, but that it's actually okay to start returning to appropriately physically distanced, but some face-to-face contact with people. We're working with DCJ to put up appropriate resources so that as things change, you're getting good current advice about what is appropriate and not appropriate at the moment. And also some of the new ways that we've been delivering services have actually been an improvement on what we were doing previously. And so thinking about how we sustain those new ways of service delivery when they've been a better thing for the community, taking our learnings. For the use of personal protective equipment, it is back to what we would normally do. So if you would normally wear gloves, if you're performing something with somebody, then you wear your gloves. The only time we change anything is if somebody is unwell, we ask them to put a mask on and we put a mask on, particularly if we physically distance. But as far as possible, if somebody is unwell, if we can delay that in face-to-face contact, that's the best way to do it. Continuing on for quite some time yet, we're going to need to keep this physical distancing of 1.5 meters, maintaining our high hand hygiene. And I know with myself, as I've become more relaxed, I've become slightly less obsessed, which is probably not a good thing. I probably need to keep that level of vigilance up for now. And also just to keep thinking about whether we keep doing service delivery slightly differently, just to minimise any residual minor risk that may be there. Right through this, providing services to vulnerable communities has been particularly important, and we've been able to support some, youth outreach services, for example, with how they could continue to provide those services during a time when generally things are lower than where other youth groups, for example, haven't been able to meet. But I would also point out that particularly for anyone providing care to a residential community, that priority testing is available because we still don't want to have any concerns about people who are working with medically vulnerable groups not being able to get testing quickly so that we can avert any other even minor potential outbreaks. So we're very concerned that if you stay home, if you're working with vulnerable people, please get tested and isolate until you get that result. And that's if you've got symptoms. If you don't have symptoms, you don't need to be tested unless public health strongly requests that you are. And that you also have a high degree of vigilance in the people that you care for and assist them getting tested if they're showing any symptoms. So generally, the advice that we've got, no matter the stage, it's washing your hands with soap and water. You don't need to use sanitizer. Soap and water works well. But if you have got access to a sanitizer, at least 60% alcohol. Keep that cough and respiratory hygiene. So if you cough or sneeze, putting it into your elbow rather than coughing into your hands. Or if you happen to be carrying around tissues, use that tissue, dispose the tissue safely, and then do the hand hygiene. One of the things that always happens to me when I'm presenting a webinar is I immediately get a scratchy nose. So just a reminder to try and avoid touching your face and trying to not shake hands or hug Small children are unlikely to give you COVID-19. So if you're in a position where a small child runs to hug you, they are not an incoming missile. You're not going to have a bad time. Just ask them perhaps nicely to step back. We're not hugging at the moment, and perform hand hygiene. It's not an end of the world thing. It is just something that we're trying to just help people keep their physical difference. If you've got frequently touched surfaces, detergent, disinfectant if somebody's unwell. Otherwise, just cleaning generally with detergent is okay. The key thing is just to keep a degree of vigilance going on. So also, if you have to transport someone in a car, if you're concerned that they're unwell, put them in the back seat, you're in the front seat, and just keep the windows open. If you're less concerned that somebody's unwell, as far as possible, just keep fresh air coming into the car rather than having things on recirculate. So with my next slide, I'm now up to the point where I'm happy to take questions. I'm not sure how that's going to work, but generally I've just also got some websites here. You can see the general New South Wales Government website where there's general information for the community. On our New South Wales Government website, if you click through to the COVID-19 information, you can see a person with a shield. We've got information for services there, and also I've got a screenshot here of the Department of Communities and Justice COVID-19 website where they also have a lot of advice and help for the sector.
So thank you for that, Jen. That was really, really valuable and useful for everybody. Now, we won't be taking questions live today, but we did ask for people to submit questions, and also Larry is our lead for the NGO sector as part of this NGO Communities of Practice. So I'll just pass it over to Larry to perhaps ask a couple of questions that are particularly relevant to the NGO sector.
Thanks, Tim. And thanks very much, Jan, for the presentation. And it is heartening to see that we are across Australia, and particularly in New South Wales, doing so well when I know that discussions amongst my peers in the drug and alcohol sector, for back in February and early March, we were very much afraid of a situation that we seem to have avoided. So it's really heartening. However, taking your points about the vigilance with the measures that have worked so well, we need to keep doing all of those things. But one question that we do have a lot of interest in is, as this pandemic is coinciding with the flu season, are flu vaccinations available for free for vulnerable populations and NGO staff delivering services to those vulnerable populations?
So flu vaccines are certainly free for many people with chronic illnesses. So they certainly are able to access them through the National Immunisation Program. I know that some GPs are concerned about their supplies, so it's a good idea to try and make sure that we phone ahead before we rock up to a GP for a vaccine. Generally speaking, some staff vaccination programs have been covering people for the free flu shot, but otherwise it's up to different individual organisations to work through their own staff immunisation strategy.
Okay, thank you for that. Look, there's just a follow-up question, and again, it's around particularly in residential settings. So in drug and alcohol, for example, in residential treatment settings, what support is available if a client or a staff member tests positive for COVID-19? And in particular, we've been asked a lot about the capacity for the LHD or the ministry to provide support for temporary accommodation for isolating those clients or staff, or both, who may have tested positive.
So absolutely, we are completely ready, willing and able to assist residential facilities with support around infection control, with support around appropriate accommodation, with support around looking after people as well for their health needs outside of COVID as well as with COVID. we're also willing to assist staff if they don't have a safe environment to self-isolate, and that safe environment could be if you're in a share house and there's no bathroom that you can have to yourself. So certainly our local health districts have all stood up that type of accommodation, and we've also worked with Department of Housing around some issues around people who might be in temporary accommodation looked after by themselves. So we're certainly very aware that a lot of people are not in a situation to safely self-isolate, and that each LHD does have plans to help protect people who can't safely self-isolate. And similarly, if a person who is a staff member who provides care can't self-isolate, again, there is appropriate accommodation available.
And thanks, Jen. And so for a residential service provider across the LHD system, their first port of call in this instance would be the contract manager?
So if somebody tests positive and they're in a residential environment, the public health unit will first of all be working out where that person is, what's happening, and then we'll provide support through the facility manager and often the staff on the ground, because sometimes if you've got a very big network of facilities, you're less able to understand, the facility manager can make business decisions, but the staff on the ground know what their particular facility is like. The public health unit will work very intensely with that particular facility, or if it's a particularly large facility, it may come up to the state public health response team, that public health emergency operations centre, or it may be the public health emergency operations centre, the state health emergency operations centre if there's a need for additional support staff at that particular facility, and the local public health unit. But we're very aware of residential facilities and the potential, particularly with anyone with chronic illnesses in residential facilities, to have a problem when they get COVID-19. And so that's one of our areas that you'll possibly be flooded with more help than you would like sometimes. Okay. But we'll be with you, I think is the thing, to really reassure you that we are acutely aware, and that's why we've made sure that there's priority testing available for people working with residential services. There's priority testing available for people who are in residential services if they have symptoms. We're really aware that this is an at-risk community, and that's why we're really ready to work with you to try and keep things as safe as possible.
Okay, so we have, just to follow up on the testing question, what about testing for all potential clients to be admitted into a residential treatment facility? I know that some of our members, for example, have had difficulties with that with their LHD. What's the story there?
So the story is, the problem is the test doesn't save us. The test will only pick you up once you have enough virus to give to other people. So if you're incubating the virus, which can be anywhere between 48 hours to 2 weeks, if we test you, say, on day 1 when you're incubating, we're not actually going to find virus there. And with some people, we won't even find virus till day 13 if they're going to get sick on day 14. So doing a test on somebody coming into a residential facility isn't going to help you a lot more than actually talking to that person about, are they well? Are the people who they've been around well? If they haven't been well, have you got the facility to sort of separate them from the general residential community for a few days whilst you see if they've got an illness that declares itself? Don't bring anyone into a residential facility if they're not well themselves. Do ask them to go for testing if they are unwell. But screening asymptomatic people coming into a residential facility is not generally recommended by the AHPPC. It's not generally recommended by New South Wales Health. And that's simply because the test can give false reassurance that this person doesn't have COVID. And so the last thing we want is someone getting tested on, say, day 1, being said they don't have COVID, and then when they get a sniffle 5 or 6 days later, everyone says, oh, they had a test, it can't be COVID. It can be COVID.
Look, I take your point. That's good. And just quickly again, re the flu vaccines. We have had some people reporting trouble with their staff of their facility being supplied flu vaccine by their LHD?
Okay, so if it's a local health district facility, we would really believe that if the LHD is the person who looks up, is the person who staffs that facility, then we would expect the LHD to be supporting staff immunisation. If it's a contracted facility, it might be more that we expect the person who is contracted to run that facility to support staff immunisation.
Okay, thank you.
Larry, that's something that the community of practice can note as a key issue for us, just to get 100% clarity for across the system, so everyone can follow the same advice.
I think it'd be good to follow this up a little bit more, but thanks, Jan, very much for your answers, particularly around the testing. That did clarify things for me anyway.
Yeah, I actually have a sign on my desk that says, unfortunately, we have no magic test for COVID-19. Because the test I'd really like to be able to do is, as soon as someone's get exposed, we'd be able to say yes or no. We don't have that test, and we're not going to have that test. So we just have to deal with an imperfect world.
Thank you.
Okay. Thank you, Jan, and it's been really great to have you here today. It's something that everyone's very interested to hear about, and most up-to-date information is really useful. And I think you've given everyone the reassurance that they need, that if they get a client that tests positive, that they'll get more love than they actually wanted in the first place. So that's great. Now it's over to you, Larry. You're the next on the agenda, which is going to give everyone online today a bit of an overview of the New South Wales Health Communities of Practice that you've been heavily involved in.
Okay, thanks, Tim. I won't take too much time up, but as you've mentioned, I've been appointed the clinical lead for the NGO Community of Practice. That represents the body of organisations and individuals who've been involved with the ministry for some time now through the NGO Advisory Committee. So it's we were able to repurpose that committee as the community of practice, and I think that's been working well. And also as a practice lead for that community of practice, I'm also a rep on the New South Wales COVID-19 Clinical Council. And that clinical council is a multidisciplinary group that gives independent and impartial advice on system-wide issues for the health system. And I think it's certainly opened my eyes to the complexity of the New South Wales health system, being part of the COVID-19 Clinical Council. Very medically focused and hospital focused, obviously, but that's the priority. But it's a great thing that the ministry has also focused on the attention on the very important role of the non-government organisation sector that's contracted to provide services on New South Wales Health's behalf to vulnerable communities in New South Wales. Jan spoke briefly about the establishment of the State Health Emergency Operations Centre and also the Public Health Emergency Operations Centres. They're two pretty critical structures, I think, for the responding to COVID-19 by the health system. And it's great to be able to have the capacity through the NGO Community of Practice group, for example, to be able to escalate issues up to the Public Health Emergency and State Health Emergency Operations Centres for consideration and resolution. There are, I think, some nearly 30 communities of practice that have been now established, and obviously mental health, primary care, palliative care, alcohol and drugs, those areas all have a community of practice, as well as all the specialist medical areas. You can look for more information about what the NGO Community of Practice has been doing via the link displayed on the screen. And for any specific issues that you feel that aren't covered by today's information session, please approach either your grant manager at the local health district level, your peak body, and or the department. if there's a considered systematic issue that the NGO community of practice should be assessing, like, for example, access to vaccinations and support with testing, then that's exactly what we will do on a case-by-case basis. I think also the community of practice has been very useful for us because we've done some very good work around some very early things, like, for example, getting a surety of funding for the NGO sector delivered by the department early on, so that people weren't anxious about whether or not their funds on a quarterly basis would continue to flow through if they were severely disrupted by COVID-19. Also helping to define the staff and workers of the NGO sector funded by the New South Wales Ministry of Health, defined as essential services and essential service workers. So that's been very supportive work, just in a couple of examples there. And I can also say that we have, as an NGO grouping within the NGO community of practice, put together a submission for consideration for some additional support funds to the NGO sector to help them cope with the changes that are being wrought by addressing COVID-19 in their service delivery sector, particularly around the expense of personal protective equipment, the additional expenses with respect to this restriction of staff and client movements across the sector, service delivery sector, and a range of other technical and telehealth support services, those sorts of things. Moving to new models of practice require additional equipment and training. So we've put together a submission for consideration. Hopefully the department will be getting back to us soon on that, because I know that the NGO sector could use a few extra resources and a bit of new money to help them embed the kind of coping and reorientation strategies that they have in place. So I think the department has sounded like they're very supportive of that idea. So we're all hoping that will be something available to us into the near future. But I think I'll probably leave it around that at the moment. Tim, if there's anything else you'd like to pick up on that I have missed.
Yeah. And we really appreciate and value the leadership that you've brought, both through the Clinical Council with the NGO communities of practice. And I mean, I've had many years experience working with NGOs, and you know, the thing that NGOs do well is that they rally, they come together, they provide leadership when that's needed, and you also advocate for the things that you really need at the moment. So I just want to thank you and your colleagues for that support and leadership. So one of the first priorities.
Alternatively, we'd like to thank you for your support. So it's been good. A good working partnership, Tim.
Yes, partnerships for health, Larry. Partnerships for health. So I'm just going to quickly spend the last part of the session today running through some of those key issues and the details that Larry just mentioned that have been raised through the communities of practice, and we've got some clarity and some runs on the board. So obviously the first priority was to provide reassurance to the New South Wales Health that New South Wales Health funding for the NGO sector will continue at this time. And I had the pleasure of doing, well, not myself personally, but the community of practice and the team I work with to publish that advice on the New South Wales Health website, which did give that reassurance that even if some services need to temporarily be suspended, that the funding for those grants would continue as normal. And noting that every NGO's circumstance will obviously be different according to local needs. NGOs need to really work closely with their grant managers to put in contingency plans around how that will work, and that it's done in a collaborative way. All grant managers across New South Wales Health have a clear understanding for the need for flexibility at this time, and as things continue to evolve into the future. Our existing policy directive that we have published on the website, and I'm sure everyone's familiar with, provides really useful guidance tools that continue to be relevant in regards to managing NGO contracts. If you need any more advice, particularly from the ministry, you can always talk to your program lead here at the ministry, and of course the branch that I work for that holds that strategic and policy lead for the NGO sector. In a nutshell, deliverables and performance indicators can be amended to enable the NGO sector to respond in the best way to assist their local communities and clients that they serve. For more information for NGOs, please see the link on the screen at the moment. Similarly, for guidance for New South Wales Health grants, see the second link on the screen. These pages are being regularly updated on our website as new information becomes available. So the second area is around service continuity, and this continues to be a priority. So it's not just about having a continuity plan up front. It's about continuing to revisit that plan for the particular NGO and grant and evolve as the situation changes in New South Wales, and continue to update what your plan is in regards to adapting and responding at this time. So to prevent the spread of COVID-19, New South Wales Health has been making changes to the way services are delivered to ensure the continuity for clients. The New South Wales Health website provides a number of key points for NGOs to consider regarding the needs and safety of clients and staff. For NGOs needing to amend their service delivery, again, please speak to your grant manager about these plans. Our existing policy directive, as I said before, does provide some useful principles around to guide this process. So the third area, which was obviously a challenge and issue for health services around the world, was access to personal protective equipment. And obviously this was a key item on the agenda for the NGO communities of practice, and how we could make sure that access, and particularly emergency access up front, was made available to our NGO providers. And also, we just want to say up front that health and safety of our NGO staff is of the utmost importance to New South Wales Health. There has been significant pressure on the global supply chain, and this has obviously impacted us. If your NGO is experiencing PPE access issues, we encourage you to use the PPE supply portal on the New South Wales Government website for industry and the community. So all you need to do is go to the New South Wales Government webpage and search PPE supplies portals for industry and the community. Then you'll see a list of over 200 suppliers who have indicated that they can service PPE needs. You can search for the suppliers by postcode and suppliers service areas. If your NGO still remains impacted on, you can make a request to the New South Wales Health to be considered for urgent supplies. We'd like you to refer to the guidelines displayed on the screen and speak with your grant managers. Please note that the second option for the NGOs the second option that I've just mentioned for urgent supply is for NGOs that have really exhausted all other options to source an alternative supply chain and worked in consultation with their grant manager. New South Wales will be giving priority, obviously, to those NGOs where there has been a confirmed case of COVID-19, and then we'll address the others according on a needs-by basis. So the other, just quickly, a couple other issues came up via the communities of practice. One was around NGO service delivery across borders. So in regards to cross-border travel, the Department of Planning and Industry and Environment has provided useful instructions on what essential services and cross borders for work. For further details on that, the information on entering and across states, please see the DPIE website. using existing New South Wales Health funds to provide things like IT resources to staff as we adapt to more of a virtual landscape. For example, providing mobile phones to clients to ensure that these essential services can continue came up as a key issue for some of our NGOs. And really, the advice is on a individual basis, and NGOs should consult with their grant managers if they're considering using New South Wales funds to provide IT resources to their vulnerable clients. And grant managers, the message is, as you always would, around making decisions around the way the funds are used, is to apply a risk management approach when considering varying those activities. We're also aware that some peak bodies have prepared guidance, like I believe the AOD sector, on optimizing the use of technology as a new service model with clients. So please contact your peak and grant managers for any further guidance on that matter. So they're the key updates we'd like to provide you today, but please keep visiting our website for further updates. Now, Larry, we've still got 12 minutes. So, I mean, I don't know if there's any NGO that you've been working with or aware of that have put in place a continuity plan or adapted in a certain way that would be useful for other NGOs to understand the way that we can be agile or flexible at this time?
Yeah, look, Tim, we've been in close contact with our members, and I'm sure all other peaks across the NGO program in New South Wales Health have been. And yes, they have been doing some very critical things. I mean, they're all accredited organisations. They have put into place COVID-19 management plans. They have made significant changes to service delivery, particularly residential services. So most of them have ceased new admissions, and they're just starting to think about that now. Most of them have been able to manage their clients in residential settings with effective hygiene, social distancing, and access to personal protective equipment. That has become it's an ongoing issue. It's not as easy to get personal protective equipment through your LHD as we would like. But then, noting that there's been a lot of advice about where to access PPE. We've heard a lot from our members about the shift away from face-to-face contact to online, webinar, telehealth, teleconferencing facilities. And most people have made fairly significant changes to the way in which they're operating to maintain contact with clients, to provide services to them remotely and through telehealth. And some of that's quite successful. Actually, a lot of it's quite successful. And there's some good thinking about ways in which we might be able to continue to integrate those kinds of processes into, return to normal service delivery whenever that happens. I think that leadership from the department, support from the peaks, and access to information networks across our own drug and alcohol peak network, for example. We've got sub-networks, and people are contacting each other and sharing information, and we're trying to facilitate that with some follow-up webinars, a little bit like this one, but which will be a little bit more interactive, but we'll probably have a lot less numbers. So that might make it easier. So I think there are a lot of learnings. I think there are a lot of opportunities for improvement into the future. I think there are a lot of opportunities that COVID-19 has thrown up for the non-government sector that we would hope into the future, the continued greater consolidation of connectedness and partnerships with LHD service providing staff and specialists would continue. And I think this whole experience has given all of us in the health sector an opportunity to look at how we've been doing business. Apart from the disruptions and the interruption to service delivery, it has shown us certain things, and I think people have responded amazingly well to the management of clients in the current circumstances, with reduced access, social distancing, infection control, and a whole other lot of problems. I'm learning about ways to get around that and still manage to provide support to clients. As I said, it's thrown up a lot of interesting learnings, and we hope to be able to continue to share that amongst each other in our service networks, and also with our partners in the LHD and the ministry, and in particular around ways in which we might reconfigure service delivery to respond to probably what's going to be another 6 to 12 to 18 months worth of COVID alertness in this state. Even if we've passed the worst of the first epidemic, we certainly don't want to see a spring back of cases and a second wave of infections. So we're going to need to be vigilant for the next 6, 12, 18 months and more. And I think that gives us the time also to continue to work collaboratively with our partners in LHDs and the ministry around models of service delivery. So I think I'll sort of shut up there because I've been gibbering on a bit. But if there's anything you'd like to respond to out of that, I'd like to hear it.
Thanks, Larry. You always keep me accountable. So no, that's really useful, and I know that you're in touch with a lot of your colleagues, and it's been really good to have that kind of contact and information to the real world and reality around what's happening in regards to the operation and delivery of NGO services. And I mean, it's one of the key messages for today, which is we need to be flexible, and not work in traditional ways. There are some services that have need to be on pause, and for good reasons. But there is no reason why the funds that were going towards those services that needed to be paused shouldn't be repurposed in a way to help us respond in an agile way and help us to even build the infrastructure that we will need moving forward, whether that's around IT or different ways that services can be delivered, make sure that clients get the services that they need where they need them. So, I mean, I think first and foremost, that's the number one bit of clarity that we need to get out to both grant managers and to NGO providers, and hopefully the community of practice have been able to do that already with the guidance we've put on the website and with today's webinar. And we'll continue to work together and jump each hurdle as they come. So we'll move into the final stages of today's webinar, which is really just to give any that weren't clarified today, or a new kind of emerging issues for the NGO sector, which is state, systematic kind of issues. We would like you to send them in to the email, the email box that we've been promoting today. And we have already been starting to make questions that are coming in and the comments from today's webinar. And we will review them, analyse them, and also raise them through the communities of practice. Or if they're a specific question to yourselves, we'll follow up and respond to your email to give you the advice that you're after. I'd also like to thank all our NGO partners, whether they're online today or not. In particular, our members that normally sit on our advisory committee for the NGO Partnerships for Health Advisory Committee. A lot of those members have directly just entered into the communities of practice while they're dealing with all the other competing priorities that everyone's dealing with at the moment. So I just want to acknowledge and thank them for their valuable contribution and for like Larry always does, as I mentioned, keeping us accountable, but also the senior leaders that from New South Wales Health that also sit on that communities of practice and the broader advisory committee. Just want to thank you for your time and the leadership and commitment that you've shown to, coming with energy to partner with the NGO sector to continue to evolve and deliver these critical services to the and patients that live in our communities. The most recent update around information, advice and guidance for the NGO sector and for New South Wales more broadly. And please get in touch along the way around that NGO communities practice email Dropbox. That continues to remain open, and it will remain open while we're responding to the COVID-19 situation in New South Wales. So in saying that, thank you to our presenters today. I hope today's session has been useful for everyone. And I'd just like to thank everyone and wish everyone a lovely Friday and weekend.
Thanks very much, Tim. And thanks to all who've logged in, and do follow up if you've got questions.